It's great to see so many of you attending the workshop to hear about the progress we are making with evidence-based cleaning. I'm Donna Brown and I'm the Managing Director for ISS Healthcare. I'm joined by Martin Kiernan, who is the Visiting Professor from the Richard Wells ReseCentre, University of West London, and Dr. Amy Gyte, who is the Senior Scientist for Biohazards from the Health and Safety Executive Science and Research Centre in Derbyshire. So we have an exciting agenda for you today, starting with Martin, who will be setting the scene and explaining what we are trying to do. And then I will also talk about why we're doing this. I will then cover our methodology, and Martin will present the results. I have to say the screen is quite small, so when we're presenting the results, we'll do our very, very best, but you will all get copies of the slide and any information you need afterwards. Amy is then going to highlight the critical link between respiratory health and cleaning, which underpins the project. I will then finish with next steps before we open the floor to questions. So, without further ado, over to Martin.
You should never clap till you've heard it, you know. I mean, it might be rubbish. So my name's Martin Kiernan. I worked in the NHS for 30 plus years as an infection prevention nurse to start with, ended up as a nurse consultant, then went into industry with Gamma, retired from there last December, got dragged back in during COVID into the Nightingale in London, but now I work with the universities here and in Australia. So I'm in the University of West London, but I'm also with Avondale University and Newcastle University in New South Wales, which I don't get to visit very often, it's fair to say. So I've had a long-term interest in, obviously, healthcare-associated infection, but particularly the environment. And basically, infection prevention is about stopping people getting new bugs. So actually, there's still a huge amount we don't know about this, how the actual mechanism by which people acquire a new organism. For gram-positives, we think it's touch, we think it's contact with contaminated surfaces, so either direct infection or colonisation. We actually don't know the true mechanism of that. Which bit do you pick up first? Do you sniff up a skin squame with a Staph aureus in it, which colonises your nose, and then people handle the nose and scratch various other moist parts of the body so the other ones get contaminated? We actually don't know the mechanism. I'm staggered about actually how much I don't know about something I've worked in for 40 years. And I'm definitely going to finish my career knowing that I know far less than I thought I knew back in 1990. Gram-negatives and C. diff are interesting because basically, it's got to be through touch and contact. It's not going to be inhalation because you go into the gut. So this is touching surfaces followed by eating. So that's how you acquire gram-negatives and C. diff. You eat nano poop, okay? Because coliforms live in the gut. That's their reservoir. So you have to become colonised with coliforms by eating something that's dropped out of somebody else's bottom. Now, I'm assuming that it's gone in through the mouth, because the only other way in, I would struggle to say that that was a really good way to go. You know, you see an E. coli clambering up the legs and going in the bottom way. I really can't see that, to be absolutely honest. So we're trying to stop people acquiring new organisms into the gut. And what we do know is that patient hand hygiene is absolutely appalling, okay? 13% before an intervention from the University of West London, from Jenny Wilson and Heather Loveday, 59% afterwards. I suspect that's still better than staff hand hygiene, even though it always says 98% on the ward door. Whereas meanwhile, back on planet Earth, it's not going to be anything like that. But by giving somebody a hand wipe to actually use before they ate was quite a good thing. But what about touch and contact? Well, when I started as a nurse, this is actually a couple of years after I started as a nurse, Dennis Mackey was a very famous microbiologist who did all the original work on IV lines, and if he spoke at a conference, everybody used to go to see him. However, what's clear is he knew nothing about the environment, and yet was coming out with statements like this. You know, the inanimate hospital environment, particularly on surfaces and in the air and in water, faucets and sink drains, contribute negligibly to hospital-acquired infection. Absolutely wrong. Will people say they're wrong? I don't think we're very good at doing that, I have to say. There's quite a few not still admitting they were wrong about COVID and how that was transmitted. But for years, nobody really wanted to listen to this. And actually, 7 years after I started in infection prevention, back in 1997, people were still writing editorials in the Journal of Hospital Infections saying that expenditure on cleaning is for aesthetic purposes only and to give people confidence when they come through the door of the organisation. That's a problem, isn't it? So if we're not concentrating on it, there's a risk, I think, if the environment becomes contaminated and then the next person into the room eats a bit that's dropped out the previous person and they get C. diff. And if you look at the literature now, you actually find that if you go into a room previously occupied by a C. diff patient, you had a 1 in 4, or 27% increased risk of getting C. diff within 90 days, but actually within a year, these things hang around. You know, they don't die easily. You have to kill them with something targeted. So that's a real issue. There's actually another study that I haven't got time to talk about in depth now, but which shows that actually if you became the next occupant or the previous person some way down the line, like 3 months, in the bed you're in, had C. diff, you're still at an increased risk because, of course, beds move out of side rooms and move around the hospital. So not only is it the room, because often when somebody has the will drop out their bottom, they're put in a side room, and then you move them. When the next one goes in, that bed goes out somewhere else because the next patient goes in there, and it's much easier to move the whole cleaned bed out so the next one can go in. So you've no idea. They did a nice study with RFID tagging beds, and so they could actually track them around the hospital. And I've been involved in this systematic review with Brett Mitchell in Australia, showing that if you go into a room where somebody previously had an infection, you've got nearly a 3 times the risk of picking up the same infection. Interestingly, we did a study with nurses asking them their attitudes to cleaning, and most would not want to go into a side room if the previous person had been infected. Therefore, we're not particularly confident we're cleaning very well. Yeah? I normally say, would you want your mum to go in? Not your mother-in-law, obviously, because that's a slightly different level of room. So we know it's a risk if we don't decontaminate properly. So, that's gone on one. I'm going to go back. I can. Okay, I'm going to keep hopping. We now have a systematic review which has blinked before your eyes. It was published in the ARIC journal with Alexander Peters because we've now got so much data. We can actually do a systematic review on randomised controlled trials. Whoever thought back in even in the early 2000s that we would have enough randomised controlled trials published in journals like The Lancet that would show attention to cleaning makes a difference. And unfortunately, I cannot give you the results of the CLEAN study done in Australia, which is a randomised controlled trial that has just been accepted as a late breaker for ECMID, so that will be presented next Monday in Barcelona. I can't give you the results, but it is about decontaminating equipment again in the room. Actually, the equipment that the staff used, like the clinical staff, did that make a difference? And I'm quite excited about that. Now, you can't just throw money at something, of course. You've got to get bang for buck, and hygiene has a cost. There's a lot of people now saying, use this latest whiz-bang machine. It's going to really solve all your problems. Unfortunately, before you use the whiz-bang machine, you've still got to do the manual cleaning. And I can find no study that says that using automated systems is cost effective. There is a study that shows a cleaning bundle with manual cleaning methods is cost effective, but nobody has done a study on an automated machine. Now, either they haven't done them, or they have done them and they haven't published the results. I don't know what's the case there. Okay? So that's interesting. So we need to get bang for buck when it comes to decontamination, because most people say you should clean high-touch surfaces regularly or more frequently, but what are they and what then causes the contamination? How does this happen? Well, at the moment we've just got a couple of studies looking at what high-touch surfaces are. People always list them, don't they, the light switch and all the rest of it. If you look at where they've been done, you've got intensive care unit and the operating theatre. And they said they looked at staff and patient activity. Patients aren't doing a lot in the operating theatre, to be honest, and they're not doing very much in the ITU either. So that really is staff activity, I think, unless they wake up and clamber over everything, by accident. So if you actually look at that picture, there's a few things that will come out in our work that will show you that wasn't necessarily right. Now, what does contaminate surfaces? Who does this? Here's a study from Alain Wolfensberger and Hugo Sachs in Switzerland looking at transmission networks and transmission dynamics, where they did a real-life evaluation of just MRSA. Do you remember MRSA? That used to be a superbug in the old days. I got sort of nostalgic tear for this not particularly antibiotic-resistant bug that caused us a lot of pain years ago, and this turns out not to be particularly a problem. So they did some sampling of the groin, axilla, the nose, dominant hands of some patients and some surfaces, and then they sampled them at 90-minute intervals, and they disinfected either the surface or they cleaned the patient's hand. And these were MRSA-positive patients. So at baseline, a third of hands and 20% of high-touch surfaces were positive. At follow-up, so every 90 minutes, they'd recontaminated the hands. Okay, and a number of environmental sites became positive every single time. So this was patient activity explaining 70% of environmental contaminations. Now you could say, oh yeah, but is that air settling? Which it could be, because there's plenty of studies that show if people are carrying it on the skin, then it goes into dust and it settles. But this is an observational study looking at what patients touched and did those surfaces become contaminated. So air would be a factor, but this is also patient touch. So what we've got no published data on a relevant organisation to us in the UK. Okay, if the studies in the States are in theatre and in the operating and the ITU, and also if they did a study in the ward anyway, it'd all be single rooms. Which is why when you read a study that says you can stop contact precautions for MRSA and some other infections, don't forget they're all in a single room in America. So it's not quite the same as leaving somebody in a 6 to 8 bedded bay over here. So we've got no data on multi-occupancy rooms, what is going on, but we do know that patient activity is responsible for significant amounts of contamination. So what we really need to be doing is looking at frequency of decontaminating high-touch crossover points. What should we be targeting? What are the patients touching a lot of, and what are the staff touching a lot of? Because we know deep in our hearts that hand hygiene is not 98%, okay? And even if it is, it definitely isn't after touching surfaces within the bed space. Okay, so I'm going to hand back to, are you doing this bit or am I? Okay. I better read it then. So what we're trying to answer. So what we actually want to work out is if we can look at our cleaning technique and looking at the cleaning frequency of frequently touched surfaces, the real frequently touched surfaces, can we reduce the bioburden and can we reduce the rates of transmission? So what we did about this, we got a trained observer to actually look at and sit in a bay and watch what was going on, okay? And this is why we're doing this. There's some emerging scientific evidence. We want continuous improvement. You know, a huge amount of expenditure goes on cleaning our organisations. Therefore, we must get some value for money, okay? But what we need to know is, are we spending the money on the right things? So are we getting efficacy? And is it making a difference? Because it is a valuable resource, which then improves the work environment for patients and staff and visitors. Visitors are going to come into this, okay? I know everybody always blames visitors for everything. Well, they have a part to play in this, but it maybe isn't them bringing in infection, although I have seen patients come in to see Granny because they feel a bit bad, but I go and visit her and they're not feeling so well, so they come in and vomit on her with norovirus. I mean, that's not so good. But generally, patients don't bring in too much, but they have a part to play here.
We spent an awful lot of time, by the way, working out what the scientific question was that we were trying to answer. We came to the conclusion, as Martin's just explained to you. But I wanted to talk to you as well about, why we're doing this in a bit more detail. Because as you heard Martin outlined, emerging scientific evidence highlights that decontamination of the environment does indeed reduce healthcare-associated infections. And we know that patient activity is responsible for significant amounts of contamination. But as you heard from Martin, there is no published data on multiple occupancy rooms. So our mission is to change that. So the purpose of this project is continuous improvement. So we are searching for the best possible way to do things with the best possible outcomes. So we want to use science-based evidence to identify the surfaces within a ward that are high crossover points and design cleaning regimes that create an environment that is not just visibly clean, but clinically clean. So ultimately this is about saving lives. One of the most valuable things or aspects to evolve from the National Standards of Healthcare Cleaning 21 was the efficacy of the cleaning process, because it highlighted how cleaning efficacy is vital to creating a safe and healthy environment for patients, visitors and staff. So we are taking that learning and building on the efficacy of the cleaning process by looking at the scientific outcomes that sit behind it. And we heard from Martin that environmental interventions are shown to reduce healthcare-associated infections, but we want to evidence what are the most effective cleaning interventions are, and that means reviewing if we should be cleaning some elements, more or less, and how we should be cleaning them. As you heard from Martin, we need more bang for our buck. So the NHS spends over £1.2 billion a year on cleaning. And we want to get the most impact and value for money, particularly as cleaning is a labour-intensive resource. You heard from Martin, you have to go in and clean rooms before you use some of the sophisticated equipment. So by identifying the elements that are most likely to become contaminated by the organisms from a patient and seeing if there is any correlation between the items that patients touch and those touched by staff, we can find the common items where targeted intervention and targeted training will absolutely have the most impact and spend our valuable cleaning resources much more wisely. We also want to improve the work environment. We believe that we owe a greater and better outcome, not just to cleaning efficacy, but to how cleaning impacts on patient staff and the environment, and our cleaning teams. We want to create a valuable piece of scientific research that challenges universal cleaning precautions, seeking to design much more sustainable cleaning solutions. So, it's taken 2 years to get to this point. The planning, the governance, and the scoping of this project has been incredibly extensive to ensure that we have everything in place to produce a credible and scientifically valid piece of work. So I'm going to share with you our methodology, and then I'm going to let Martin share the findings with you, which are really, really interesting. As I said, I apologise that you probably won't see too much of the graphs. Okay, so we undertook a scoping exercise in 2022 to collect preliminary data that we used to optimise our protocol. And this taught us that governance around the observation methodology was key to proving data integrity. We developed a really targeted and detailed data collection template. We stipulated how many observation hours and for how long. We found that if you observe without breaks, then you stop seeing things. We stipulated where the observer must be located within the ward so that we observe from the same angle. But this was also to minimise subconscious bias, such as observing what we find most interesting. Observer consistency was also a really key factor, and the scenarios that allow subjective views to be drawn had to be minimised or eliminated completely. For example, most waste bins have a foot pedal. If somebody touches the waste bin with their foot, is that a touch? Well, the answer is no. But if someone touches the waste bin with their hand, with or without a glove, is that a touch? Well, the answer is yes. So, we did all the scoping in 2022, and then in 2023, we embarked on a 10-week programme of observation. In total, we made 267 hours of observations across 5 different types of wards, focusing on 4-bedded bays only. The ward staff and cleaning teams knew why we were there so that they understood the purpose of the project, and we were observing what was being touched rather than what they were doing. And that was to ensure that they carried about their normal routines as they would do day to day. Observations were undertaken at all times of the day, evenings and weekends, and we observed activity on the ward for 1 hour each morning and 1 hour each afternoon for a period of 4 weeks each, making sure that we captured the morning activity, such as the consultants' rounds, phlebotomists, visits from physios, drugs trolleys, etc. Interestingly, we did not observe hand hygiene. That would have been a can of worms. Okay, so patient privity was always our priority. Now, the observers witnessed some very distressing situations which affected our ability to observe. There were also times when observing that it felt very intrusive if patients were suffering. And this was a stark reminder to us that our healthcare teams experience day in, day out these situations, and it made us question if we focus enough on pastoral care for our teams. Do we prepare them and support them enough for the many different types of healthcare environments that they are working in? It was also a reminder of how the behaviour of our staff can impact a patient's well-being, both positively and negatively, and highlighted the importance of ensuring that they are given the opportunity to do the best job they can. by training them and equipping them properly with the most effective PPE and tools. We used 7 different observers, and our lead observer, Patrick's in the room, did around 70% of the observations. Each observer was consistently briefed prior to carrying out an observation, and were provided with briefing notes, a preview of the data collection template, and clarity around the definitions that could be open to interpretation. As I said, when is a touch a touch? For elements that are frequently touched, such as overbed tables, the default touch point was the top and the edge, with the opportunity for the observer to individually comment how many times it was touched underneath. And touch frequencies were manually recorded, and then we transferred the data electronically for consolidation and for analysis. And finally, we used a click meter to record the number of people entries onto the 4-bedded bay that we were observing. And this actually proved just how busy the wards were. And some of these findings are quite surprising.
Let's have a look at some of the results. Number of entries into a 4-bedded bay. Average number of entries actually didn't differ enormously. I know everybody seems to think mornings are much busier than afternoons, but actually a number of people coming in and out, 22 and 17, 22 in the morning, 17 in the afternoon, not enormously different on average. Which I think shows you that the NHS isn't quite what it used to be, where the consultant ward round used to happen first thing in the morning and then it went quiet during the day. And actually, quiet weekends don't happen either. And I know in my own organisation we don't need as many cleaners at the weekend. Well, that's not true, is it? Because the activity is exactly the same without half the services, which is a bit of a problem. The morning entries, we think, were slightly elevated because there are generally a few more medics around in the morning, but there really wasn't an enormous amount of difference on the surgical ward. Obviously, in surgery, they're off to theatre anyway. Medical assessment bay, a little bit busier in the morning, 21 to 16. Activity, though, still consistent, and Saturday was actually one of the busiest weekends. I've no idea what happened in Derby that Saturday, but it'd be interesting to know. Number of entries on the gastro ward, pretty similar, to be honest. 15 in the morning, 13 in the afternoon. Again, weekend activity exactly the same as weekdays. So every day is the same pretty much. Care of the elderly, exactly the same in the morning and the afternoon, near enough, 22 to 21. Weekends, exactly the same. A lot of nursing staff moving around, though, on this, which you would expect, I think, with elderly care, where people have maybe a little bit more support. And then the orthopaedic trauma ward, busier in the morning because the surgeons tend to go off to theatre. Weekend activity still pretty much the same, though, and general activity is quite low because the patients aren't moving around very much. So if you can move these days, you're out, I think. Okay, so if you look at the actual number of surfaces people touch within a bed, within a bay, okay, 80% of the activity is mostly nurses who are going around touching everything. Okay, but 20% of the surfaces are touched by patients. So there is a significant amount of patient activity, normally within the bed space, although not exclusively within their bed space. Okay, so the patients are the second largest group, but actually 10% of the touches going on are visitors who tend to turn into octopuses when they walk through the door and touch quite a lot of things, especially around the patient's bed space, but also without of that as well. The other old categories are much lower, and the medics don't tend to touch very much at all. Interestingly, the cleaning staff don't touch many items because they're normally cleaning them, so is that classed as a touch? If you actually look at the most touched element, I'll take you straight to the right-hand side of that chart, which is the light switch that everybody says is a high touch point, but really it isn't. Okay, so everybody goes, oh yeah, light switch is rubbish. But come to the left-hand side of this chart, the most touched item is the overbed table. Okay, and that does not figure. In that picture I showed you of a high touch point earlier on, that is not on there at all. Patients are touching it all the time. Staff touch it a lot as well. The second most touched item is the curtains. Okay, then we're on to the bed and mattress. Then we're on to the patient's chair. Then we're on to the visitor's chair as well. And also the notes trolley gets touched. The notes at the end of the bed get touched as well. Shifts down the line then. If you look at by who's touching what, actually the overbed tables are touched a lot by staff, but they're also touched a lot by patients, obviously, and they're touched a lot by visitors. Because the staff, to get to the patient, has to move the overbed table. Where is the patient eating their food off? Their table. Is it cleaned between each meal? And if it was, what would happen? People maybe wipe the middle of it. Who touches the table at the middle? It's not a seance, is it? You're going to grab the edges to move it. And if you're about to put a meal plate down and you were going to wipe the table, you probably just wipe the bit where the tray goes, and then the patient grabs the table to pull it towards them, or you move the table towards them. And I suspect if you did a hand hygiene observation on touching the overbed table and hand hygiene, you would get somewhat less than 98%. Yeah? And I really like the fact that the staff knew what we were doing in this, because it's no threat to them. Whereas if you go onto ward and even if we go on with a clipboard as an infection prevention practitioner, everybody migrates to the sink anyway. But if you announce we're doing a hand hygiene audit today, you're going to get 110% compliance. So that's a real issue. So the patients and the staff and the visitors are all touching the tables. The curtains are being touched a lot by the staff, but sometimes by the patients and sometimes by the visitors. Interestingly, the notes at the end of the bed are touched a lot by staff. Who knows, electronic patient record may sort that out, but actually the visitors come and have a good rummage through that as well. So it's really quite interesting looking at what people are touching, but if you're looking at what people touch a lot of and all the staff groups, you're looking at the overbed table. The computer on wheels is generally staff. The medicines trolley is actually touched a lot. You know that medicines trolley that's self-cleaning? That really gets clean when the dust is so high that you put some tablets in it and it disappears into the dust level. Yeah, if you look at by patient and visitor, the visitors, I want you to look at the visitor's chair. Another self-cleaning item that is never singular to that bed. It comes out of the pile and goes to the bed. It gets left by the bed, so the staff then handle it and put it back in the pile. And the next time it goes to a patient, it goes into a completely different bed space. Now, you wouldn't move the patient's chair every day to a different bed space, and it's like shuffling a pack of cards. But that's what happens with this. And the patient's relatives are handling that. They're handling the overbed table because they're putting things on it. They're handling the locker. I'm not blaming them. They're doing what they're going to do, but I'm not sure we educate patients' relatives well enough. Maybe you should think about decontaminating your hands before you're touching areas within this. But I've never seen, the patient's chair, the visitor's chair, be on any great cleaning schedule. And whose job would it be anyway? It gets cleaned if it's got a stain on it, but that's probably about it. So to me, there's a target there that nobody's ever looked at. If you look at most frequently touched surfaces combined by wards, it's pretty much constant across, apart from the orthopaedic ward, the elderly ward, where it's actually the blood pressure monitor was actually touched a hell of a lot on that unit. But generally, it's overbed tables and curtains right the way across the board. So there's an opportunity. So just to summarise that, nurses touch most of the surfaces, but the patients touch a lot, apart from orthopaedic and trauma, where they're not moving very much and they can't. It's what's within arm's reach. But in some of the wards, like gastro, where you're going to have potentially a lot of enteric transmission, the patients are responsible for a lot of surface touching because they're often a lot more mobile. Yeah. Visitors, a bit more on orthopaedic trauma because they're coming to help their relative. So they're busy touching stuff and they're going to touch and fetch stuff. So we should really be looking at these data and seeing if there's anything we can do about this, and is there an area we can target, which we think there is, to see if we can make a bit of a difference. So key findings then, there's this myth that mornings are busier than afternoons and the weekends are quiet. Absolutely not the case. The nurses do touch multiple surfaces across the room. I suspect that contact with the surface is the least complied with hand hygiene moment of the 5 moments, certainly within the bed space. Patients touch multiple surfaces, but mostly the overbed table, which for me is the major crossover point. That's the thing that jumped out on me in this one. And for me, visitors may not bring in infections themselves, but they may have a role to play in transmission that we haven't fully recognised because of the amount of contact they do.
Hi, my name's Amy Gyte. I'm a scientist from the Health and Safety Executive, so I'm coming at this from a completely different perspective to probably the majority of you in the room. So I work at the HSE Science and Research Centre in Buxton in Derbyshire, and we're primarily concerned with respiratory health in cleaners. So there's been a growing body of evidence that the occupational health of cleaners may be at the detriment of their work and the disinfectant and cleaning products that they are exposed to. And how this kind of fits in with ISS's work is your cleaning staff are an important part, or I would say probably the most important part at reducing the bioburden on your wards and in your hospitals. And if we don't look after our staff, they're not going to be there to be that part of that critical part of the chain of removing the decontamination, the contamination that's in that hospital. We need to look after our staff. We need to make sure that they are fit and healthy when they leave work as when they arrive. So we've been looking at this for quite a while, and it kind of fits in very nicely with the work that ISS have been doing in this area. So obviously the work that ISS are doing is a long-term study. We've been working on it for 2 years, and we're not there yet. And obviously we've still got quite a long way to go. But there's things that I believe that you can be doing in your hospitals today when you go home to be helping along this path. And it's a bit boring, but actually it's doing a really good risk assessment. Have you really thought in your risk assessments about all the routes of exposure for your cleaners? Have you really thought about, so we might think about splashes to eyes when we're decanting disinfectant chemicals. We might think about slips and trips. We might think about dermal exposure and the use of gloves to prevent people getting contamination on their skin. But have you also thought about inhalation? The work I've done over the past kind of 5 or 6 years has suggested that that's probably lower down the chain of things that we are thinking about. But when you're doing a risk assessment, you need to be thinking about all the routes of exposure that cleaner could be exposed to disinfectant chemicals. And they are chemicals. It's a chemical. It's going to cause harm. It kills bugs and bacteria in your hospital wards. It's therefore likely to kill bugs and bacteria in that human person's lung as well. So you need to be thinking about all the routes of exposure for that cleaner to those chemicals. When we're doing a risk assessment, I would also like you to think about different areas of your hospital and not just using a broad brushstroke approach to everywhere in your hospital. So think about each areas of your hospital. What's the infection risk in that area? Is it the same in a surgical ward as it is in an outpatient waiting room? That's for you to decide, and therefore to adapt your cleaning regime and the products that you are using to meet that infection risk. Because the more you use disinfectant chemicals, the more risk of exposure there is for the people who are using those disinfectant chemicals, the more risk there is for causing harm and degradation to the surfaces that you're cleaning. So you need to be able to balance that occupational health with the infection risk in that area. So think about these questions. Do we need to disinfect this area? How frequently do we need to disinfect it? Who will do that? Will it be domestics, cleaning staff, or will it be clinical staff? Have your clinical staff been trained how to clean? The majority of cases that I've experienced is that they are not. What disinfectant product will you use? Do you need to use a chemical disinfectant product? How will you prepare it, apply it, use it? What are the hazards associated with that? And how are you going to control exposure to that product? And this is the area that I think people really struggle with, is how do we control exposure to those disinfectant products? So looking at the hierarchy of control, if you're not aware of this, you need to Google it. You need to be looking at it when you're doing a risk assessment. So elimination is the top of the hierarchy. That's the first thing that you need to be thinking about. Physically remove the hazard. Do we need to disinfect this area, yes or no? If you don't, then you've eliminated that risk. Can you replace the hazard? Substitution. Do we need to use chemicals, or could we be using a different chemical instead of a high hazard chemical? Engineering control, so you isolate your workforce from that hazard. Could you increase ventilation? How will you do that? I appreciate that's really, really difficult when you're working in hospitals where the windows don't open, or they open by about this much, or you've got a fire door that you have to prop open with your cleaner's trolley, things like that. I appreciate it's really difficult. Changing the way people work. Are your cleaning staff truly empowered? Do they really know the risks associated with the work that they're doing? Do they feel that they can ask the patient, would you mind if I open the window whilst I'm cleaning your room? It would be beneficial for the patient and it would be beneficial for me. But do they really feel that they can say that? Personal protective equipment, respiratory protective equipment is the bottom of that hierarchy of control, because that should be your absolute last resort that you are using. And when you are using respiratory protective equipment, an FFP3 mask, a surgical mask, will not protect against chemical exposure. If you are using respiratory protective equipment, you need to be looking at the type of respiratory protective equipment that is suitable for the risk that you are trying to eliminate. And if that is chemical exposure, that is not a surgical mask. And you need to be speaking to your personal protective equipment supplier to ensure that you have got the right personal protective equipment. There is more advice on the HSE website if you want to have a look.
We're now in the testing and intervention phase. So we're now establishing the baseline contamination to identify what the current levels are. And then we're going to use different interventions, swabbing before and after, to determine how much each intervention reduces the level of bioburden. So the interventions will include changing chemicals and materials, changing equipment, changes to the frequency of cleaning, changes to the time of cleaning, and the impact of training. So as you can see, we've gone back to basics with the project. We're reviewing exactly all the elements that we clean, and we're building it from there. And we hope that you can see that we're creating an invaluable piece of research that we'll continue to share with the healthcare community. We're hoping that the science will show us where we need to focus our efforts to maximise cleaning efficacy, reduce risk, change behaviours, be more efficient, reduce costs, and drive sustainability. So I've rushed through that. I've not said everything, because we've run out of time. I know you want to get to your workshop, but thank you so much.